Thank you for the introduction, and thank you very much to the organizers for inviting me. Although the pandemic has kept for the last 2 years has kept us indoors, it has been a once in a lifetime opportunity to relearn almost the whole spectrum of neurology, because COVID and its inflammatory and its infective problems that it has produced has led to a huge number of manifestations. So I'll try to simplify it and take you through some of the spectrum that we have seen and that has been described in literature. As of yesterday, more than 261 million cases of coronavirus have been described, and over 5 million deaths. And now with the latest variant, that is the Omicron variant being described, the pandemic is coming back in a big way in Europe, and God knows how we are going to fare again in India, whether we'll need booster doses, etc. But those are all topics for another discussion. With COVID, almost about 4% of patients' neurological complications are the primary cause of death. And in one of the largest Chinese cohorts of about 70,000 patients, it was seen that of the patients who had underlying neurological diseases, these were the ones who had a high rate of recrudescence or secondary neurological complications, which varied from about 6 to 36%. Now, there are different mechanisms of entry of the virus into the CNS. One is through the vascular, the most favored one is now through the vascular pericyte, which lines the endothelial wall of the blood vessels. The other is through the olfactory nerves, through the sustentacular and the supporting cells directly into the CNS. And the third is through the breach of the blood-brain barrier. We all know this figure. This is a very common figure which shows us the viral load in the body, followed by the seroconversion. The IgG antibodies almost appear simultaneously with the IgM antibodies. And as you can see here, in most of the cases, the neurological complications can actually occur anywhere from the incubation period till the post-COVID period. But most of them occur in the hyperinflammatory phase, when the host immune response or the dysregulated host immune response is the one that starts creating a cytokine storm and havoc in the body. Similarly, COVID is associated with both an endotheliopathy, whereby it destroys the endothelium, leads to release of VWF monomers and produces a TTP-like picture, as well as it can produce a thrombocytopathy by involving the platelets, in increasing platelet aggregation and platelet activation, causing microthrombosis, causing deposition of immune complexes, and leading to vasculitis and deposition of immune complexes within various small blood vessels in any part of the body. Now, other mechanisms of CNS disease in COVID include antibody-mediated responses, sepsis or hypertension, hypoxia-related problems, and ACE2 receptor downregulation, which leads to increased angiotensin activity, vasoconstriction, inflammation, prothrombotic state, and endotheliitis, microthrombosis, cytokine storm, and direct viral invasion into the CNS. Now, this is just to give you an overview of the 7 major categories of neurological complications that occur in COVID. The first one is a delirium or an encephalopathy without any distinctive focal signs, without any distinctive MRI or CSF abnormalities. The second one is inflammatory CNS syndrome such as encephalitis, ADEM, AHLE, or myelitis. The third one is ischemic strokes associated with the prothrombotic state. The fourth are peripheral neurological disorders. The fifth are concurrent CNS infections or secondary infections. The sixth are both MISC and MISA. And the seventh are a constellation of miscellaneous disorders which so far do not yet fit into any of these categories. Now, delirium is the commonest. It occurs in almost about 20 to 30% of COVID patients, and it's considered a barometer or a very vital sign for severe illness, because it is one of the predictors that most patients may require either some mask ventilation or may require some sort of invasive ventilation. And as you all know, there are different types of delirium. It's very easy for the ICU physician to pick up hyperactive delirium, because these patients are usually agitated and restless. But hypoactive or the somnolent or lethargic delirium is very poorly picked up by ICU physicians. And also these patients require a significantly longer time to improvement following the COVID encephalopathy. As you can see from this table, there's a huge list of neurological complications which can occur. I'll try to take you through some of these. The inflammatory and infective complications include, like I said, delirium, different types of demyelinating illnesses, the opsoclonus myoclonus syndrome, rhombencephalitis, autoimmune limbic encephalitis, as well as the neurological complications in the multisystem inflammatory syndrome, which are most often caused by rhabdomyolysis, critical illness myopathy, immune-mediated myositis, and thrombosis. Now, there is a lot of data that suggests, initially it was thought that the direct invasion of the virus into the CNS through the olfactory nerves led to direct viral neuronopathic or cytopathic toxicity, and that led to the inflammatory manifestations. But later on, numerous studies have showed that the CSF in COVID patients has a paucity of neuroinflammatory changes, and very few studies have actually demonstrated the pickup of SARS-CoV within the CSF, leading to a concept that this is probably more due to a hyperinflammatory or a host immune response rather than direct COVID-related neuronopathic effects. Also, there are a number of drugs that have been bandied around as cures for COVID, which we've all used at some points of time in the last 2 years. These include chloroquine and hydroxychloroquine, interferons, methylprednisolone, all of which, tocilizumab, all of which by themselves contribute significantly to CNS and PNS dysfunction. Now, one of the, for example, the neuromuscular diseases that associated with COVID include GBS, myopathy, and rhabdomyopathy. But the antivirals that have been used and the antimalarials such as hydroxychloroquine and chloroquine can also produce a toxic myopathy and rhabdomyolysis, neuropathy, myasthenia gravis, etc. Colchicine toxicity is another big threat that probably many of us may have probably missed. Colchicine, as you know, is a microtubule formation and inhibitor, and the problem is that after 7 days it is capable of producing myopathy and neuropathy. Unless the disorder is suspected per se, it's very difficult to diagnose it, because there is no single test to diagnose this disorder. Measuring colchicine levels in the serum is not useful. Hemodialysis doesn't remove it, and there's no antidote. So largely the management is supportive. So this is one of the reasons why we should probably not use colchicine in COVID patients. As I said before, delirium and stroke are significantly associated with the risk of mortality. Delirium leads to almost an odds ratio of 1.39, and stroke increases the odds ratio by 3.1. Also, obese patients tend to have a worse outcome in COVID because of a large number of factors, including chronic inflammation, increased ACE2 levels, as well as an increased predisposition to coagulopathy, impaired viral clearance, and increased predisposition to cytokine storm and other such factors. Now, also this is probably very important for neurosurgery colleagues, because in patients who test positive for COVID-19 and who undergo elective surgery, some of these patients have a significantly higher risk of complications, morbidity, and mortality. And these complications are more in patients who have end-stage renal disease, those who have congestive heart failure, those who have underlying cirrhosis, women, patients who undergo neurosurgical procedures, and as well as patients who have COPD. The reason for this is not known, but this is probably should serve as a warning to neurosurgeons to take a high-risk consent when they take them for surgery in the presence of active COVID. So these are some of the autoimmune and hemorrhagic complications of CNS. You can see multifocal diffusion restriction, as well as multifocal contrast enhancing lesions in the MRI. These are cases of acute disseminated encephalomyelitis, as well as leash. You can see multiple small microbleeds, as well as involvement of the brachial plexus in different MRI sequences. These are patients with ADEM who have multifocal brain and spinal cord lesions. These are patients who have concurrent systemic thromboembolism involving both the cranial as well as the extracranial circulation. This is the patient who had multiple pulmonary emboli as well as a large MCA infarction. Patients can develop both para-infectious as well as post-infectious rhombencephalitis, and rhombencephalitis is thought to occur because of entry of the virus through the trigeminal nerve into the pons. This is a relatively new entity called critical illness associated microbleeds, where multiple microbleeds occur at the gray-white matter border as well as involve the corpus callosum. Concurrent infections with COVID-19 can occur because COVID-19 itself overwhelms the immune system and can lead to a relative energy. Thereby, this is one of our patients who had HIV along with COVID with multiple other microabscesses due to both fungi and bacteria. Inflammatory myopathies can occur with COVID. As I said before, these are largely due to the hyper-reactive immune response rather than direct viral myophagia or myophagocytosis. And most of these are definitely immune-mediated and may respond to steroids. So there's a whole host of acute COVID and post-COVID-19 complications. As you know, post-COVID also can lead to a significant number of neurological complications, of which the most common are brain fog, a persistent anosmia or ageusia, can lead to a prolonged prothrombotic state and can lead to post-COVID strokes or vascular occlusions. So since I've come to the end of my time, I'll stop my talk here. Thank you, and I would like to answer any questions if you have any doubts.
Can I ask?
Sure.